Hi, everybody. I'm Jessica Marie, and I am here today to present on premenstrual dysphoric disorder. So let's go ahead and get started. I'll share my screen with you. Okay, here we are, premenstrual dysphoric disorder. I hope you all don't mind if I refer to my notes through the presentation, and I hope you enjoy. Okay, beginning with historical background and prevalence. Premenstrual dysphoric disorder, or PMDD, impacts approximately 2 to 6% of people who experience menses and has been recorded across the world, many different continents. PMDD was added to the DSM-5 Section 2 in mood disorders. In the DSM-4 previously, it had been included in an appendix referred to as the criteria, sets, and axes provided for further study. So the developers of the DSM-4 felt that PMDD needed further development, and then once the DSM-5 came around, they felt that those development criteria had been met, and they moved it into the mood disorder category, depressive disorders category. Now, unfortunately, there's not a lot of documentation on the evolution of PMDD, but there has been extensive empirical research over the last 2 decades that have established PMDD as a legitimate diagnosis. Okay. All right, diagnostic criteria. So criteria A really refers to the characteristics of PMDD that delineate it from other mood disorders. Specifically, the symptoms experienced during PMDD follow the menstrual cycle. So the symptoms become their most severe the week prior to menses and then subside either on the first day of menses or within a few days. And so this is the main defining criteria of PMDD that delineates it from other diagnoses. Now, criteria B, we are seeing common mood-related symptoms, labile mood, irritability, sadness, and anxiety. Okay, now criteria C, we begin to see more of the cognitive and physical symptoms of PMDD, such as difficulty with concentration, disturbances in regular sleep patterns, a sense of being overwhelmed or out of control, and then also physical symptoms like aching joints and muscles. And at this point in the diagnostic criteria, we really start to get an idea of the diversity of symptoms that a person could potentially experience as a result of PMDD. And at this point, we've recognized that there have been emotional symptoms and now cognitive and physical symptoms that somebody can experience. And in criteria D, we establish that the symptoms experienced by the client cause significant distress and or disturbance in their everyday parts of their life. So relationships, work, those kinds of things. Okay. Criteria E is where we rule out other similar diagnoses. PMDD is very similar to other diagnoses in its symptomatology. And so this is the point in diagnosis that we rule out personality disorders or other mood or depressive disorders. And when we get to criteria F, this is the point where we establish in the diagnostic process that there needs to be a record of the client's symptoms over the span of their menstrual cycle. Those symptoms need to be rated on a daily basis, and that process needs to be followed through for at least 2 full menstrual cycles, usually about 60 days. And so that documentation is necessary to establish an official diagnosis of PMDD. And criteria G establishes that there are no physiological explanations of the presenting symptoms. So there's no biological illness or any sort of substances being consumed by the client that could impact these kinds of symptoms. Okay, risk factors for PMDD. I found it interesting that while both genetic and environmental factors contribute to premenstrual symptoms, only environmental factors have been shown empirically to contribute to the development of PMDD. Those environmental risk factors include stress, history of interpersonal trauma, seasonal changes, sociocultural aspects of female sexual behavior in general, and female gender roles in particular. I found the last two to be somewhat gendering, and unfortunately found that gendering to be a common theme in the research that I did about PMDD through the DSM-5 and what the DSM-5 has to say about this diagnosis. So we'll discuss more of that later. Okay, so diagnosis of PMDD. As we've established, in order to give an official diagnosis of PMDD, there needs to be a record taken of the severity of symptoms over the span of a client's menstrual cycle, over 2 of those menstrual cycles. So how we accomplish that, there's a great tool called the Daily Rating of Severity of Problem, or the DRSP, that will track the diverse symptoms presented by PMDD over the span of 2 months. I'm not a huge fan of the title, but it's a great tool and it presents a lot of information. So let's go take a look. Okay, so this is the DRSP. This is the chart that the client fills out on a daily basis, giving each symptom a rating from 1 to 6. 1 being not experiencing the symptom at all, 6 being the severity is pretty extreme that day. As you can see, there's quite a diverse list of symptoms. This is a long list. And my apologies that I couldn't bring to you a clearer chart because of how many symptoms are included. It gets pretty blurry and the print is very small, so my apologies. But a few examples of the symptoms on this list are experiencing conflict with people in your life, trouble with sleep disturbances, feeling overwhelmed, frequent mood swings, and then joints and muscle pain. In addition to tracking these symptoms, other information is collected on this chart, including to what extent did any of these symptoms contribute to challenges or conflicts with the people in your life, and also what were the characteristics of your menstrual flow on that day if it was present. Okay, so now we will discuss Heather, our case study. Heather is a 36-year-old Caucasian female referred to counseling by her medical physician for severe anxiety and mood disturbance solely between that last week of her menstrual cycle. Heather reports being short-tempered with her family, feeling overwhelmed, having sudden bouts of tearfulness, and actually did report 2 instances of passive SI within the last 90 days. And the onset of these symptoms has been the last 18 months. Okay, so Heather's background. Heather is a stay-at-home mom of 3. She has 3 children, ages 5, 3, and 18 months. Her husband is a finance executive, and they live in Philadelphia. Heather grew up in a rural town. She is the oldest of 5 children. Her father was a state senator, and her mother was a full-time homemaker. Heather has a group of girlfriends that she grew up with. She met them in high school and considers them to be her primary source of emotional support. An event of note for Heather, when Heather's father passed away in 2016, the family discovered that he had been carrying on an affair with a woman in his office for the last decade. And to this day, Heather's mother refuses to discuss the affair. So this is an event that has strongly impacted Heather, and she still continues to ruminate over it today. Okay, so diagnosis. For Heather, I decided that an appropriate diagnosis was premenstrual dysphoric disorder, provisional. We obviously can't give an official diagnosis of PMDD until we've gone through the 60-day review and charting of her symptoms to determine whether or not they follow her menstrual cycle. The diagnostic criteria that she has met thus far, I included criteria A because we are beginning the process of recording those symptoms. What she has reported at this point is that these symptoms do follow her menstrual cycle. And so I included that in the satisfied criteria. From the mood impacted symptoms, excuse me, Heather has reported labile mood, a lot of mood swings, marked irritability, severe anxiety in moments, difficulty sleeping in a hypersomnia or insomnia, a sense of being overwhelmed or out of control. Is what the symptoms that she has reported at this point. So I included criteria D because these symptoms do cause her distress, and they are causing her interpersonal conflict with her husband and with her children. And we included criteria G because Heather reports that she's not on any medication, she doesn't use any illicit substances, and her primary care physician did some testing prior to referring her that ruled out hyperthyroidism or any sort of organic disorder that may be causing these symptoms. Okay, cultural and ethnic considerations. Let's begin with Heather. So, the cultural considerations for Heather's case, Heather identifies as devoutly Christian, and her family is active in their church. The impact of her religious beliefs has been shown at this point. When she met with her primary care physician, she was offered hormone-based birth control to try to alleviate these symptoms, and she denied that as these methods of birth control are against her religious beliefs, which is completely fine. We definitely want to respect that. There are definitely other options that we can pursue for treatment. And something I felt was important to note, in the DSM-5, one of the risk factors for this diagnosis is traditional female gender roles, which from a tertiary standpoint, we could say that Heather fits into traditional female gender roles. She's a stay-at-home mother. But the DSM-5 doesn't go on to describe that term in further detail, and so it gave me pause and wondered about whether or not that was a risk factor that was legitimate. Okay, so cultural and ethnic considerations for premenstrual dysphoric disorder in general. PMDD has been observed across cultures and global regions, and there is more research necessary to determine whether or not instances of PMDD are impacted by race or ethnicity, but hopefully we will establish that research, and we can take a look closer in that. And though PMDD is not considered to be culture bound, which means that it's not directly impacted, somebody's culture wouldn't contribute to them developing PMDD, the way that an individual client's culture will interact with this diagnosis is on their expression of the individual symptoms and on the likeliness that they will seek help. So at this point, I wanted to discuss the gendering of this diagnosis by the DSM-5. And I have to admit that I definitely bought into that gendering. My case study aligns with that kind of traditional gender role for women. And it wasn't until I read the line in the DSM-5 about PMDD exclusively impacting one gender, which I don't believe is the case, that I realized how this diagnosis might uniquely impact transgendered men and might actually make their presentation and diagnosis of PMDD more complicated and potentially traumatizing than it would be for a menstruating cisgendered female. This realization made me want to rewrite my case study, but I opted not to, though I thought about it. And I think that this is an important consideration when looking at this diagnosis and working with the transgender population, that in the future, if I were working with a transgendered male that presented in this matter, that I would consider PMDD as a diagnosis in the future. Okay, treatment options. So, SSRIs, or selective serotonin reuptake inhibitors, have shown to be effective in the treatment of PMDD in about half of the folks that experience it, and more effective than other methods that are common, so hormone-based birth control or vitamin supplements. CBT would be my main method of treatment, at least until we could establish an official diagnosis of PMDD. Then I might discuss the SSRI medication route with the client. Until then, I would choose to employ cognitive behavioral therapy, specifically focusing on rumination and emotion-related impulsivity, as research has shown that use of CBT focusing on these particular characteristics are uniquely helpful for this presentation of PMDD and its particular symptomatology. So in addition, I would incorporate a frequent suicide assessment in my treatment, as PMDD is closely associated with suicidality, both ideation and behavior. I would want to check in regularly about any suicidal ideation that Heather may be having, and then also create a safety plan with Heather in the event that any SI pops up again. And she has already reported 2 passive instances of suicidal ideation in the recent history. So that's going to be important. Okay, goals for Heather. So, goal number 1, Heather would like to decrease her experiences of overwhelm during the week prior to her period. That makes perfect sense. She's starting to feel overwhelmed, and she begins to take that out on her kids, which is something that really disturbs her. So, the behavioral objective that we will first begin to pursue in pursuit of this goal is I will employ person-centered therapy and CBT during weekly sessions, with every other week focusing on rumination specifically to decrease Heather's experience of overwhelm. And then we will continue to discuss that week over week, every other week focusing on rumination. Behavioral objective 2. Heather will practice coping mechanisms that we identified together in session. We'll look to find coping mechanisms that resonate with Heather, including methods of mindfulness and breathing exercises. And then Heather will practice those coping mechanisms once a day in the middle of her day, whether she's feeling overwhelmed or not. And what that will do, hopefully, is to give her some practice in those coping mechanisms and allow her to feel more comfortable in utilizing them when she does feel overwhelmed. Behavioral objective 3. Heather will journal about her experience for 15 minutes at the end of her day, right before bedtime. She will explore her experiences of overwhelm, if they occurred that day, what led up to those experiences, were there particular thoughts that she was having in that moment, and then also journal about the experience of utilizing those coping mechanisms during moments of overwhelm or not, and she will discuss how they impacted her, if they were helpful at all, and how that worked out. And then we will review those journal entries once a week at our sessions. All right. Goal number 2, Heather would like to decrease instances of losing her patience with her kids and her family. And what this looks like for her is yelling, speaking in a harsh tone, and this is outside of any sort of disciplinary activity. And she would like to decrease these behaviors to once a week, the week prior to her period, which would be a significant decrease for her. So, the first behavioral objective that we will pursue to accomplish this goal, we will continue the use of cognitive behavioral therapy. And every other week, outside of the weeks that we focus on rumination, every other week we will focus on emotion related impulsivity, which has been shown to empirically to assist in alleviating symptoms of PMDD. And also, specifically for Heather, because she's having these emotional outbursts, we want to figure out ways for her to control that impulsivity in the moment so she's not losing her patience with her kids and with her family. Behavioral objective 2. Heather will practice identified coping mechanisms and in the middle of her day to kind of see if they help, whether she has lost her patience or not, and specifically employing them when she feels like she's going to lose her patience. So again, methods of mindfulness, breathing exercises, even some neurofeedback we could practice with that. And so she will be practicing those skills to develop them so she feels more comfortable in using them when she does feel like she's losing control. And behavioral objective 3 for this goal, again, Heather will journal about her experience. If there was an instance of her losing her patience that day, she'll talk about what preceded that kind of loss of control. If she remembers what the content was, and we'll talk about the specifics of the event. She'll journal about those. And reflect on those and then bring them into our session. And then again, we'll be practicing those coping mechanisms, so the methods of mindfulness or breathing exercises, whether she feels out of control or not, so she can develop those skills for when she does feel out of control. And then we'll review the results in her journal entries once a week. All right, and the third goal. Heather and myself will begin to explore a provisional diagnosis of PMDD over the next 60 days, or 2 average menstrual cycles for Heather, to establish whether the diagnosis is appropriate. So behavioral objective 1, Heather will complete the daily record of severity of problem before bedtime each day for the next 60 days, gauging whether symptoms she experienced that day, what symptoms she experienced that day, and the severity, to establish whether or not these symptoms are actually following the pattern of her menstrual cycle. And then Heather will bring in the DRSP to our weekly sessions, and we will review her symptomatology and how things are looking, if things are becoming more severe or less, and tracking those to determine whether or not they do sync up with her menstrual cycle. And if that is the case, then we can go ahead and make that diagnosis of premenstrual dysphoric disorder official, and we can rule out other diagnoses like bipolar disorder or even personality disorder. Okay, so that is premenstrual dysphoric disorder, and these are my references. I hope you have enjoyed my presentation, and thank you so much for your time and attention. Thanks, everybody. Have a great day.